Hi, everyone, and welcome to this afternoon's session, Inpatient Naloxone Kit Distribution, our first steps into hospital-based harm reduction initiatives, led by Paola, Nikodem, and Michael Roach. I'm Kate Hardy, and I'm the Network Director for the MetaPHI program, and I will be moderating this afternoon's session. I'll start off by just introducing you to our speakers. Paola is the Regional Lead for Education and Quality and Addiction Services at Health Sciences North. Her experiences as a registered nurse include working with individuals living with or at risk of HIV, hepatitis C, managed alcohol program, and substance use clinics. In 2016, Paola completed her master's in public health with a nursing specialization and has since been working in leadership positions within addiction services at HSN, including interim clinical manager of addiction services in various regional lead positions. Michael Roach is the Northeastern Ontario Regional Lead for Rapid Access Addictions Medicine and Addiction Medicine Consult teams. He's also the manager for Sudbury's RAAM Clinic and the interim manager for Health Sciences North, AMCT. Michael has a Master of Nursing and varied experience working in education, nursing regulation, mental health, long-term care, community health, and as a school health nurse in London, England. He's active in multiple research studies and publications. He also has a strong background in program development and evaluation. So thank you, Paola and Mike, for being here with us this afternoon. I will just remind our audience to submit any questions that you might have into the chat function just at the side of your screen. You can feel welcome to submit them at any time, and I'll read them out at the end. I'll also remind you that there is an evaluation link that will pop up toward the end of the presentation. You'll just see a blue banner toward the top of your screen. We really appreciate if you'll take a few minutes just to complete that. I'll also remind you that following this session will be just a short wrap-up to the conference that we're inviting you to join us for before you head off. So thanks so much, and Paola and Mike, I will hand it over to you.
Good afternoon, everybody. Thank you very much for staying this late on a Saturday in the conference. We do appreciate it. My name is Michael Roach, and I'm going to start off this presentation, which is basically our first steps into introducing harm reduction initiatives into the hospital. And I believe both Paola and I agree that this is a very important first step that we have both been working on for quite some time now. So just to start off, we have received no funding for this initiative. We do get in-kind support from our hospital, which is Health Sciences North here in Sudbury, specifically from an admin perspective through staffing and logistical support, mainly from data perspective and giving us the time to work on this. And we have no potential conflict of interests. As for specific disclosures, neither Paola or I have anything to disclose. And what we're going to be doing today is we're going to be discussing the rationale for distributing take-home naloxone kits in inpatient environments, developing an implementation plan for take-home naloxone kit distribution for your facility, and adapting our implementation toolkit for use in your own facility. And basically, a step-by-step of what we're going to be going through is really just kind of introducing you to what we did, how we got started, why we thought this was a necessary initiative for our hospital, what our toolkit looks like, what successes and challenges we've come across, and the big questions that we've had since starting our rollout, and then a little bit about next steps on what we're going to be doing next. But before that, we do have some questions for you. So we're going to be doing about 4 polling questions. And basically, when the questions pop up, I'm going to have you scroll down to where the actual question is. But we're really going to ask you 4 separate questions. The first one is, does your organization distribute naloxone kits to patients or their loved ones? If your organization is handing out naloxone kits, which areas are you handing out of? Do you know how or when to distribute a naloxone kit? And what are your current challenges being faced around naloxone distribution? So I'll start with the first one. All right. I think just with the timing, I think we can move on to the next poll.
All right, so this is the second question. So the same thing, if you can just scroll down. If your organization is handing out naloxone kits, which areas are you handing out of? So there's either we're not handing out kits, a community organization, hospital outpatient programs, hospital inpatient programs, or all of the above, or other. And this is helpful because, just knowing what we're about to speak to, we see a lot of variety, and we've had a lot of people actually reaching out to us to ask more questions about the inpatient distribution. So this helps give us an idea of where things are at. So we have 3 so far. So 1 is not handing out, 2 are handing out outpatient programs, 1 hospital inpatient programs, and 1 is all of the above. Awesome. Another 1 not.
All right. So the third question, do you know how or when to distribute naloxone kits? All right. Next question.
All right, this is the last one, I think. Is there 4? We are, what are your current challenges being faced around naloxone distribution? So policy challenges, legal concerns or challenges, administrative, environmental, staff hesitancy, or all of the above. And again, this just helps kind of set the tone for us as we're speaking and going through the presentation as well. So some policy challenges, legal concerns or questions, environmental, all of the above. So we have answers to all of these questions. Hopefully we can answer them all. Right. So I'm assuming that the majority of the people that are on the call are aware of what naloxone is, but for those of you, just in case you aren't, it is a medication that is will rapidly and temporarily reverse the effects of an opioid overdose by knocking that opioid off the receptors in the brain. It is temporary though, so it does buy only 20 to 30 extra minutes to get some help. And we like to set the stage with this as we're, spreading across to the other units that this may be new to, because many people don't know about naloxone. They know that it's a medication that they may use on the inpatient units, but not aware of what's actually happening in the community and how we're handing out kits.
So, really to give you an understanding of the why we decided to start handing out kits within our inpatient units, it really comes down to what we and basically everybody in Ontario is facing with this opioid or this overdose crisis. So a few facts about our region. We in 2020 became the public health region with the highest rate of opioid-related deaths per capita. So in 2020, we had 52. The number continually goes up every year, but it was a huge jump in the year 2020. And most of the public health units within our community, within the Northeast, have very, very high rates of opioid overdose-related deaths. When we're comparing this to the rest of Ontario, or Ontario as a larger group, it's about 16 per 100,000. And as I said, we're at 52. So throughout 2019, 2020, and as things have been progressing, in 2019, we had a total for our entire region, 56 opioid-related deaths. In 2020, that went up to 106. And now, so far, based on the stats that have been collected, 32 between January and March of this year. As for paramedic responses, we had 468 in 2019, 683 in 2020, and so far this year, between January and August, we had 566. So large increases in the number of individuals overdosing and the number of people calling ambulances for opioid-related incidences. At the hospital, our numbers are also continuing to go up. So we track our opioid poisoning rates that are presenting to the emergency department. And as you can see from this, we have jumped up significantly between last year and this year as well. So we went up from 2019 to 2020, and 2020 to 2021 has gone up even further. We have an addictions medicine consult team at our hospital, and these are some of the stats that we're seeing. We're seeing about same number of individuals within the hospital who use opiates as well as alcohol. When we compare that to our RAAM clinic, we see about 60% of our clients are alcohol users, whereas in the hospital, it's about 50-50. So lots of sick people coming to the hospital with opioid use concerns.
So as we've been rolling this out across the hospital, we're often asked by everyone, why do we need to distribute naloxone kits in the hospital? And we give kudos to our Medify friends for providing this information, but this is actually one of the slides that we are using in our presentations with the managers and nurse clinicians. And Michael will get into how we did all of that, those meetings. But really just to ground people and understand, you know, they say, well, there's pharmacies that are handing out kits. There's agencies in the community that are handing out kits. We're super busy. Why do we need to do this? So the responses to that is that other agencies may not be open. People are discharged at all hours of the day, especially from the emergency departments. Many people that are taking prescribed opioids do not know the risk. So being able to have those conversations with them as well. Many people are not willing to go to the other agencies to actually get the kits or go to pharmacies, stigma, and many patients who use opioids, as we know, are at high risk of overdose when they're discharged. So the really great thing that this information has helped with is starting those conversations and, you know, make sure that it's better to hand these kits out as much as possible and get them into the hands of everyone. So it's been really great. We also talk about the Ontario Naloxone program as we're engaging with the managers, and just kind of go through the timeline of back in 2013, that's when the injectable naloxone was available through the hepatitis C programs, then pharmacies, and then public health, and just the timeline of how things have gone. And for us, and you'll see this has taken quite a while. So in 2018 at Health Sciences North, we began distributing naloxone kits out of our mental health and addictions program and our emergency department. And this was done with training through our public health and mostly just our addictions teams that we're distributing in addition to the emerge. We tried to get them on the inpatient units at the time, and we tried to get medical directives for naloxone administration in suspected opioid overdoses, particularly on our outpatient sites that don't have code blue teams to help respond to codes. And we were met with a lot of challenges. But as you kind of continue along the timeline, you can see that now we are finally having some buy-in, which is really amazing. Sad that it's taken so long, but now we are handing out on the inpatient units, and we also have medical directives for administration, and we'll get into that as well.
So how we approached our inpatient naloxone distribution really came down to a couple of different steps, and really we ended up receiving approval from the ministry to distribute kits on our inpatient units. So this negotiation or this discussion happened with our vice president, and they ended up giving us the ability to do a pilot study or a pilot launch within our hospital. So the original plan was to roll out on 3 units and then ramp up from there based on capacity and need. So the next step was we finalized our memorandum of understanding with our public health department, our public health unit. They were instrumental in getting this program off the ground, and are where we get our kits from. So we had conversations with them about capacity, the number of kits we'd likely need on a monthly basis, and we've been working very closely with them as we've been amping up our service. I developed a proposal to spread across the organization. I presented it to senior leadership and came out with a fairly segmented plan in waves on how we were going to roll this out. We then presented to the managers. We presented to Nurse Clinician Forum. Other departments like Leadership and Learning is our education department, because we wanted to do a very robust education rollout. Paola then started developing a training module for the distribution. We developed templates for units. And then a toolkit, which we'll be going through as part of this presentation. Then we determined the process for ordering and storage corporate-wide, and we revised our hospital procedures around kit distribution. Ultimately speaking, the idea behind all of this was to make it as simple as possible for the frontline user of this service. What we wanted to do was make it so that we were coming there with everything that they would need to get started, so that they could hit the ground running and start handing out kits as soon as possible. Another look at it from a different lens. Really, we took a little bit of an approach using this model here, where we identified through our assessment, identified the highest risk units within our hospital. We then also looked at unit readiness and contextual variables within those units before we decided to roll them out. A good example of a contextual variable, one of our units with the highest rates of individuals who are admitted with an opioid use disorder also had a lot of COVID cases. So COVID kept throwing a bit of a wrench into most of our planning. But really, we were looking at it from, are they ready? Are we able to roll it out now? Are they overwhelmed? And then kind of adjusting as we went. We then developed our education plan, distribution rollout plan, schedule, and toolkit. And then we took a three-wave approach to how we wanted to roll this out. So we had our first wave, which was our high-risk units. Our wave 2 was our moderate risk units, and our wave 3 was our lower risk units. We have, again, that addictions medicine consult team. We use them to fill the gaps between units who are still onboarding. So if somebody needed a naloxone kit and that unit hadn't quite yet rolled out, our addictions medicine consult team clinicians could go and talk to the individual and hand out kits. From an evaluation perspective, we're looking at the number of kits distributed, confidence of staff, number of training being done, and those types of variables. And this is kind of how it actually worked out. We had our phase 1, which started with our AMCT. We have an addictions medicine unit where we rolled it out, acute psychiatry, and our child and adolescent mental health program. Our phase 2 included our respiratory unit, general medicine, cardiology, and IRU. That was in the summer of 2021. Right now, we're in the process of rolling out on our maternity unit, nephrology, chronic pain, and our ortho neuro unit. And this winter, we're going to be rolling out pretty much the rest of the units. So general surgery, oncology, CMU, ICU, and our pediatric unit. So some tips for when you're planning on rolling these out. First and foremost, as I said, this is a very collaborative initiative with our public health unit. So it's very important, if you're going through your public health unit, to get their support before reaching out to the ministry. Again, we got permission by the ministry to do this in inpatient units, and all of our kits are being supplied by our public health unit. So it's a very important relationship to build and maintain if you haven't already done so. Identify units based on opioid presentations, risks, needs, and prescribing habits. The other thing that we were really trying hard to do was to make this a little bit more of an open approach. So whether an individual is using opioids illicitly or not, if they are being prescribed opioids, they should be getting a naloxone kit when they're leaving the hospital. The other thing that we looked at was the number of people admitted to the units, the number of consultations that our addictions medicine consult team received, and that's really how we identified our highest risk units. Be flexible in your implementation plan. We've been accepted and embraced by a lot of the units that we've been rolling out to, but we also took a little bit of a light approach to the rollout. We didn't want to force it when the units weren't ready. And develop a contingency plan in the interim. So I mentioned our addictions medicine consult team. We also had our addictions medicine unit staff reaching out to units as well. So these were all areas that we could continue to facilitate our rollout, even if the unit itself wasn't quite ready. The other big one that Paola can talk a little bit more detail about was we had high hopes of doing in-person training for our naloxone rollout, and again, COVID kind of got in the way of that. So we did kind of create a more virtual approach to our learning. So from a change agency perspective, again, try to make this as easy as possible for the units. Develop your toolkit and education materials before your meeting with the managers or the frontline staff. Was the way that we approached it, and it was accepted very well. So how we implemented it, we did an introductory meeting with the management teams. We presented our toolkit. We did process meeting and development of unit specific standards of work. So we met with them to help them build their standards of work and their rollout plan. We did touch points as they began to implement, and then we continue to keep in touch with them through their monthly data submission.
So this next section we'll go through is the actual toolkit that we developed. And we literally put it in a binder, and we always say with a red sparkly bow, but we should actually add one on. As Michael has said, with the intentions of making it as easy as possible. We know everyone is strapped. When we tried many years ago, when we look back at that timeline, many people were saying it's just another thing we need to do. And now we have COVID added in the mix. So we really wanted to make it as easy as possible. So we're going to go through all of these really quickly. And if anyone is interested in copies, you can see it on the presentation that'll be shared, but also you can email us. Our email addresses are at the end, and we can share it with you as well. Something we did forget to add on here is we also developed a naloxone kit distribution procedure. So we are a large organization. We need policies and procedures for everything. And this just outlines all of the steps for the units as well. So we can share that if you're interested. So this first document is the contact tracking log, and this is actually developed from public health. We just made a few modifications on our end. And every time a kit is distributed, the rationale behind this form is to make sure we're able to obtain the data from the units so that we can submit it to public health so that they can submit it to the Ministry of Health. So you can put a name, you don't have to. I told people initials are fine. We just need the number of kits handed out in this little section here. And it's also the education reminder of staff of what they need to go through as a checklist with people. As Michael said, we helped develop standards of work for kit distribution. So we had that initial meeting with the managers and the nurse educators. Once we had the buy-in from them and we gave them the toolkit and said, this is what it is, these are the next steps, we would have this one-on-one meeting with the nurse educators to go through what can it look like on your unit specifically, because they're the ones that are helping with all of this rollout. So it goes through, step one, we're putting the checklist, which we'll review in a moment. We're putting that on the patient chart. Step two, we're going through the education, and this is what the education is. and we're giving the kit to the patient, what charting and documentation needs to be done, and what to revisit on discharge. So again, making sure the person still has their naloxone kit, that they didn't happen to lose it or use it when they were out off the unit for whatever reason. And this picture on the side is actually one of the little containers that the staff put together in their closet where they store the naloxone kit. So they just put a little duotang at the inside, and it has their contact tracking log, the standard of work, and the checklist inside, so that they can just grab it and go. Everything's in one spot, as easy as possible for staff. We also developed a standard work for kit ordering. We have not used this yet, but we figured we would share. This is just another consideration as you're speaking with your public health units. Ours locally, you have to actually go pick up your kits from public health. We're fortunate it is literally like on the same property across the street, but it is still, you have to go pick up these boxes. So we did work out a process. We just don't have the staff availability at the moment to be doing this ordering. So right now, when we get the monthly stats from everyone about how many kits they've handed out, how many people have been educated, we're also getting an order request for them for what they need replaced. Then we place the order, and either Michael or I go get it. This is the public health training manual. So they actually developed this back in 2020. They've been updating it every year, I think, since they started handing them out. And it's really the education. So if you want to hand out a naloxone kit to someone, this is the 15-page Bible of what you need to know inside of here, when to give it, signs of an overdose, and all of that. As Michael mentioned earlier, we had wanted to do one-on-one, face-to-face training with people, and we recognized that is obviously very challenging in times of COVID. Going to the units are pretty tricky. People's time is also very limited, but also we have way too many people in a 24-hour organization to be able to train everyone face-to-face or in groups. So we actually ended up creating a self-learning package, which is all online on our education portal, with all of the information from this training manual in there. And then we do go onto the units and attend huddles and connect with the staff if they do have any questions as well. So that's kind of the education part. We developed this quick reference, again, for that in-person training we had hoped for, but it's a nice one-pager FAQ document that the staff are able to refer to in the moment if they want a little refresher. And we had put a test on the back, but we haven't actually used that. This training checklist, I think, has been one of the most utilized documents in the toolkit. So this is, again, from public health, and it's a 2-page document on what you need to know. So when people are grabbing that kit, where they grab the naloxone kit out of it and they grab the little duotang with all of their documents, this checklist is in there, quite a few copies, so the staff can just rip it out, bring it to the bedside. I mean, our teams are more comfortable and do this often enough that they're able to recite it without the checklist. But these units that are starting to do it, this is all very new to them. So it's been really great because it opens up the dialogue with patients and their families. It opens up to, by offering it to everyone, which is on the standard of work, every admission into the unit, we're not only saying we think you need a naloxone kit because we know you have a history of substance use. We're offering it to everyone. So you never know whose children or parents or anyone that could benefit. So that's really great. So it goes through, overdose prevention techniques, signs of opioid overdoses, steps to actually administering the naloxone. So remembering that this is training people that don't have healthcare backgrounds, that may not know CPR, that may not know how to administer an intranasal medication. So they're going into the basics for that. This is, again, public health's reporting form. We figured we'd throw it in here because we don't know, where everyone is from and how developed their public health programs are for the naloxone kit distribution. But this is basically what we're submitting to them every month. And this is that patient chart form that I spoke about earlier. And we developed this to put on the patient chart, mostly as a communication tool between staff, because if you have you have 24-hour shifts. It's really hard. You lose a lot of information as people are coming and going, the staff are coming and going. So this is really just to say, on admission, check mark, they've accepted the kit, they want 2 kits. We did the education, we put it in their belongings, we charted it in the progress notes. Or if they declined it, you're checking that off as a communication tool and saying, I've done the education, but we may want to check back in with them on discharge. So the bottom part is that part there. On discharge, confirm that they still have the kit, they haven't used it. And if they don't want it, that's okay, but we still offer the education on it. The toolkit also has material from public health, so different posters to hang around on how to give naloxone, what you're looking for in opioid overdoses, and signs for the unit about the naloxone kits being there. We wanted to give more stats on this, but we figured this would probably just be the cleanest one to share. Distribution to date. So as Michael said, we started this back in February when we got the approval, but by the time we got everything organized and started training people, we're looking between April and August here, and we've handed out 165 kits on the inpatient units during this time period. The reason it's kind of all over the place, but as you move up in the months, we're getting higher numbers is because we've onboarded more units. So at the beginning, it was just the addictions medicine unit and the addictions medicine consult team. Then we onboarded psychiatry, the children's mental health and addictions unit. Then we onboarded, we included emerge in our numbers, and then we started with the medical floors like Michael went through on that timeline. So successes so far, the staff on the units identifying the needs for the kit. So that has been really great. We've said it already. There was no interest before, but now there is, and it's coming from people that are just swamped, overwhelmed, overworked, but they still want to do this. So we know that's really amazing. Having the conversations about substance use across the organization. So we were trying to have these before as well, but this has just given us a nice in and a great way to kind of sneak in and have those conversations and connect people. Stocking has been going well. That was a concern at the beginning. How many do we need? Can we keep up with, can public health keep up with how many we're ordering? And Michael did a really good job digging into the stats of, which units, how many people are admitted with substance use on each unit. And then we calculated, then we can also hand it out to family or friends or their loved ones that are visiting, but also how many people aren't disclosing their substance use as well. So we've added that on as well. Success, the snowball effect for the new units is really, we're getting the feedback that this has been the easiest rollout ever, which is why I think we need to put a red bow on those toolkits. But we're getting really positive feedback from everyone about how it's easy and the staff are doing it and it's going well.
So as for the challenges, COVID has created all kinds of delays in a lot of programming, but also this as well. So for some units, we'd be making progress, and then all of a sudden we get like a huge surge of COVID clients. So then we'd have to kind of take a little bit of a step back. But it seemed to have stabilized, and we've seemed to be able to have moved forward quite well despite COVID. One of the biggest concerns, and we've really had two sides of this concern, is about liability. And I'll go into a little bit more detail about that in a future slide, but really there was concerns about missing people. There was concerns about the rollout, and really the strategy that we took to it was to have the addictions medicine consult team as our backups. Ordering and picking up does require work. So it's generally either Paola or me going to public health and picking up big boxes of naloxone kits and bringing them over to the hospital to distribute them out to the units. We've created a process for storage within our purchasing department, but we haven't actually implemented that yet. So we're still working on that one. There was hesitation at the beginning, particularly related to this being one more thing in the middle of the pandemic. But just like what Paola said, we started getting some units onboarded, and it very quickly snowballed. So a lot of units wanted to start handing out the kits. They saw the successes that some of the other units were having, and they wanted to be onboarded. And then tracking challenges, we tend to have some some difficulty with some of our units who are handing out kits and then forgetting to document them in the way that we need to document them for public health. But we've been able to track kits and make sure that people are getting them regardless of those tracking challenges.
And a tip that I haven't even shared with Michael about that is we started keeping inventory. So if one unit started with 20 kits, they say, Paola, I only have 10 left, but only 5 people documented that they handed out kits. We're able to figure out that obviously some were missed there. So these are some of those questions asked. And like we said, Michael said in the beginning, we've had a lot of organizations reach out to us asking how we deal with some of these challenges that have come up. So the first one is pharmacy versus public health. So on that timeline you saw back in, I think it was 2018 or 2020, Michael had tried to connect with the pharmacy through the hospital and figure out, how do we start distributing the kits here? And it came back with, it was quite complicated because of a lot of requirements on their end, plus the cost associated with it. It wasn't like going through the ministry and getting it through the health unit. So once, we didn't really get into this, but how this kind of came to be was there was a coroner's inquest into an overdose that happened after someone was discharged from the hospital. And with that recommendation was made that we begin distributing the naloxone kits. So that's how it kind of, as Michael talked about, getting that buy-in from everyone, from senior leadership and engaging everyone. That's kind of where it came from. So since then, I kind of jumped all over here. Sorry, I apologize. We've engaged with public health and realized that that is the most appropriate way to go, because we're trying to get them out into the community, whereas our pharmacy is using medications more for administration in the hospital.
So the liability and legal questions that have come up really did stem through 2 different lenses. The first was we were originally granted a pilot project to roll out onto 3 units, and our medical leads had questioned that if it's being offered on some units and not others, are we not providing equitable access to the naloxone kits? So that one was very easily answered in 2 ways. The first way was we just decided to roll it out to the whole hospital instead of doing it to pilot sites. And the second way was to have our addictions medicine consult team as the backup. So while we were rolling it out to different units, we were sending communication to let people know that they could reach out to AMCT like they always could, but now we also have the ability to hand out naloxone kits. The second liability and legal question came from nursing staff, and it was really around like if they should have handed out a kit and didn't for whatever reason, could they be held accountable? And it really comes down to where or why they didn't hand out the kit. Ultimately speaking, we have legal support and liability coverage for our staff that protects them in any of these situations. And as long as they were not, not handing it out to cause harm, that seemed to be fine with our legal department. So it just becomes part of their discharge planning and discharge process with the clients.
Extra burden on staff we already touched on, but really, again, just for the interest of time, everyone's swamped, overworked, exhausted. So that was a big concern. And the way we've approached it was trying to make it as absolutely easy as possible, from the education being available online, and handing that toolkit to them, and offering any assistance whenever needed.
The last point there is really down to definitions. So we very early on delineated between these three options. So there's distribution. That's where you're handing out the naloxone kit to the patients when they're being discharged from the hospital. There's administration. That's where you're absolutely administering the naloxone to the patient while they're in the hospital. And then there's dispensing, which is really from a pharmacy perspective. So we did not go through our pharmacy department. We did communicate with them. We met with them. We talked and strategized about this naloxone distribution. And at the end of the day, this is a public health distribution, very similar to what we do in our outpatient programs. So we aren't going through pharmacy. We're going through public health, and that's how we're handing out the kits themselves. So as we said, this is just one of many things that we are doing at Health Sciences North that would be considered harm reduction approaches. We have both a harm reduction committee and created a harm reduction philosophy at HSN. And both of these 2 points really do stem from our strategic plan. So in 2019, our hospital came up with a new strategic plan. That strategic plan outlined as one of the objectives that regardless of where the person presents, they should be able to get access to substance use treatment, regardless of where they present in the hospital system. And from there, we developed our harm reduction philosophy. So our philosophy does state that we are going to do our best to provide or reduce harm where possible with our clients. And that led to our harm reduction committee, where we meet quite frequently with hospital units as well as community members to discuss harm reduction approaches to the way that we are providing care.
These are just some other examples, and we only have a little bit left, and I see Dr. Kahan's comment or question in the comments, so I'll save that for last. But some of the other things that have all stemmed from those committees, but also we did a needs assessment around substance use at the hospital back in March, and we did surveys with HSN staff, with patients and their loved ones, and also some of our community partners, just to get an idea of what are some of the gaps at HSN for providing care for individuals that are using substances. And a lot of that came back around education for staff, and understanding processes, and looking at policies and procedures. So these are just some of the things, the alcohol pour procedure. This is something that's been being done for forever at the hospital, but there's no clear way of how it's done across the organization in a standardized way. And so that, the nurses aren't going out on their shift to buy alcohol from the LCBO and bring it back for a patient that can't go out and get it themselves. Cannabis, same thing. So we already had a procedure, but it was from prior to cannabis becoming legal. So needing to kind of just bring that forward and update it. Searches in contraband, and we're working on developing pre-printed order sets. So when someone's admitted to the hospital, when do you do hepatitis C testing, HIV, all of that. But when the hepatitis C antibody comes back positive, the next step is to do the RNA, so you don't need to call the doctor and bug them for an order. Substance use admissions and Suboxone as well. Looking at our histories and admissions, and trying to just fix the wording on there to make sure, we're not asking inappropriate questions, that we are asking the correct questions around substance use as well. So to go back to the naloxone medical directive question. So this is where we should almost add that back on this slide. So distribution, administration, dispensing, and directive, because it's been quite confusing for a lot of people as we've connected. So we're trying to really separate the naloxone kit distribution process, but also the naloxone administration process. So there is a hospital-wide procedure for the naloxone kit distribution to actually hand kits out to people. We didn't need a medical directive for that. We've gone through all the channels to get that approved through our medical advisory committee as well. So they're aware of it happening, but they're not administering anything. So that's the procedure part for this work. The second part is the medical directive for actually administering the kit. And that is one that has been a lot more challenging, Dr. Kahan, to get, because I don't know if you were on the timeline part. We tried back in 2018 to do this across HSN, and we were unsuccessful. We were only able to do it at our outpatient locations within the mental health and addictions program, so that because they're off-site and they don't have a code blue team to respond to codes. So if you were at our Cedar Street location and there was someone overdosing, they can go grab a kit, they can administer it, they'll still call 911 and go through all of the process. But on the inpatient unit at the time, again, back in 2018, they were saying, you know what, we've got code blue. This isn't not that it's not a priority, but we have a response process already developed. Now, with all of the changes and all of this work being done, at the beginning of the year when the addictions medicine unit opened up in March, we revised the medical directive to include the addictions medicine unit. And when we actually presented on it, the rest of the hospital was saying, well, why aren't the rest of us on this? Why were we excluded from this medical directive? And we explained that at the time, it was because it was just the unit was opening up and we wanted to make sure that right away we had access to it there. And because we honestly had so many challenges historically that we know it's a bigger process to get it approved across the whole organization. So we're almost there. I've got my fingers crossed that we can get it approved shortly. The only thing that's slowing us down right now is the pediatrics component. So we're leaning towards just leaving it as an adult medical directive. So we're working on that still. There was one more thing I wanted to say about the medical directive, and I can't remember. There needs to be the training, so we're working on the training process with that. It's a big rollout. What I was going to say is the units that are really asking for it now and saying we don't want to wait for this medical directive, we've advised them, the physicians are kind of doing standing orders on the unit for PRN, so as needed naloxone for suspected opioid overdoses. And we actually did that on the addictions medicine unit as well before this directive got approved. So they're just writing in the order sets, you have the naloxone IM or sub-Q, however they want to order it for PRN, so that it's covering. People are able to administer before the code team actually gets there. So if they know, it's actually saving quite a bit of time, which is pretty amazing. So nurses in other hospitals have told us they can't give a patient anything, not a Tylenol, not a naloxone kit without a verbal or written order. So that's where it comes back to this wording of the distribution, administration, dispensing. They're not dispensing a medication. They're distributing a kit. So I don't know if that dispensing automatically scares everyone because you're giving the medication, right? I don't know if that's you speaking, Dr. Kahan, or typing, sorry. So, and the procedure does have the approval from the medical advisory committee as well. So they know that that's happening. Does that answer the question? I don't know, Michael, if you have anything to add.
Only that, again, we've set this up very similar to how we had set up a lot of our outpatient programs. This is a collaborative approach with us in public health. And our pharmacy is not involved in this at all. So it's very similar to our nurses being able to hand out naloxone kits in our outpatient programs. And again, we got that ministry approval for this approach as well.
And something else that Michael said is really linking it back to the strategic plan. And I think we don't give that enough credit to how much we've been able to get buy-in across the organization, because we're always able to say this goes back to number 10, number 11, and explain it there. So distribution versus dispensing is the key. Absolutely. As soon as we changed that language with pharmacy in particular, it really changed everything. So we have, if you feel free, Kate, I'm taking over your job. If you still have questions, add them in there, but we've put our contact information up here on the screen as well. And we are more than happy to share any of the documents or answer more questions as well.
Well, thank you, Paola and Mike, for taking the time to review that with us, and for having the sort of informal dialogue in the chat there. As Mel said, this is something that we see coming up all over the province. Really appreciate your sort of guidance on how you've managed to make this work in Sudbury. So with that said, we do have about 5 minutes before session end. I would invite anyone that's with us to add your questions to the chat. We'd love to hear from you.
We could also circulate the medical directive as well, the more updated version, which is across the organization, if that's helpful to anyone. Email. I mean, I don't know if you're if people want to reach out, or is there a way that we can just share with everyone that attended or wants it?
Folks that are interested, reach out to Mike and Paola. That's wonderful.
And we're more than willing to share anything that we've developed for this. The toolkit, obviously, you'll have to alter it to meet your needs. The MOU, whatever you need to share, or you need to get this off the ground. Like Paola said, we've seen real progress in our hospital for people being on board with a lot of the stuff that we're rolling out, and I do feel that it came from senior leadership recognizing the need in our community.
When you bring it back to I'm not a stats person, but Michael does a really great job at always bringing it back to the data, and people are just, they don't know what's going on. If they're not involved in the addictions field, that they're hearing about this all of the time, they are just so surprised with how bad things are and how many people are dying. So that's been very helpful as well to bring it back to the stats.
Okay, well, thank you so much again, Michael and Paola, for being with us this afternoon. I know it's the very end of the conference. We really appreciate you sticking around for this, sharing your expertise. And of course, I know you'll be hearing from some of the audience members. So thank you once again. We will be posting the slides through the website, the Medify website, so folks can look out on the listserv for an announcement of when those have been posted. There will be a PDF of them, and then of course the recorded version of this presentation will be available within a couple of months once it's all edited. So thank you. I invite everyone to fill out the evaluation form. I don't see it in the banner quite yet, but it will be emailed to you at the end of the day. And of course, we have the conference wrap-up session starting in just 2 minutes. If you're willing to stick around for that, we would appreciate it. So thank you, everyone. Really appreciate you being here.